And thank you everyone for joining us today. I, Amit Saxena, along with my colleague Dr. Deepika Chabra from Medical Services, Jagsonpal Pharmaceuticals, are pleased to welcome you all to this medico-legal webinar every Sunday morning organized by IMA South Delhi Branch. This is a knowledge-sharing initiative of Jagsonpal, makers of LycoRed Metadec Indocap. We would like to express our gratitude and warm and hearty welcomes to the esteemed experts and attendees. And now I request Dr. G.S. Grewal, Honorary Secretary, to kindly initiate the session.
Thank you, Amit, and namaskar and good morning to all of you. It is a great privilege and pleasure to announce the Sunday morning webinar series by the IMA South Delhi Branch. We are committed to take up those topics which are of interest to the doctors of all specialties, which affect their day-to-day work. You have ample exposure to academics in various CMEs going around, but there are many topics of very important interest and affecting day-to-day practice which do not find sponsors and therefore become difficult to hold during lectures, in seminars at hotels, etc. So these are topics that IMA South Delhi Branch is taking up to present to all its members and all members of Delhi Medical Association and anywhere around in India. We are starting the series today and shall carry on. We welcome suggestions from our viewers on what topics they would like to also have a webinar in coming weeks. And also any other suggestions how to improve this webinar, how we can make it more interactive. We have experts coming who will be speaking. And now I invite our worthy president, Dr. Chanchal Pal, to formally start these webinar series and give her welcome address. Dr. Chanchal Pal, please.
Thank you, Dr. J.S. Grewal. Good morning indeed. And it's very heartening to see already 23 participants early in the morning on Sunday. And I am sure more will be joining. Season's greeting to all of you. After festivities, it is again time for our academics, which IMA South Delhi Branch is known for. And we had this desire to have webinars on regular basis. And as Dr. J.S. Grewal rightly said, these are the topics which are very important, should reach to each and everybody beyond the boundaries of IMA South Delhi Branch. It's been hosted by IMA South Delhi Branch, but we are inviting and we are open to every medical fraternity. And we have very renowned speaker here, and we will be actually continuing this throughout the year and maybe beyond that. So these are especially on medical legal cases, because it's very important that what you should write in prescription, where you should protect yourself, how the law can protect yourself. And if we get somebody who is a doctor and lawyer as well, सोने पे सुहागा है. So इस बार जो फर्स्ट टाइम हम लोग शुरू कर रहे हैं वो ये है telemedicine. Telemedicine means teleprescription, teleconsultations. Quite a few of us were doing it earlier also, but COVID had forced all of us to do, and also forced legal code to allow us to do that. But especially in COVID, most of us were doing, and this has helped a lot of patients. but at the same time, we should know what we should write, what we should not write, how should we conduct while doing teleconsultation. So make sure that we don't get involved in any legal hassle. So to know that, we have today our worthy speaker, Dr. Tushar Rai, who is senior cardiologist at National Heart Institute, and he has done his DM from Edinburgh, cardiology from England, MRCP from Edinburgh, and he's done his law from Meerut Institute. So Dr. Tushar Roy is very learned person. मेरे को तो ये लगता है इतना पढ़ कैसे लिए ये, because after doing DM from Maulana Azad Medical College, and he MBBS, then he did his DM from PGI Chandigarh, then he went on to do his MRCP from Edinburgh, then he went on to do his LLB from Meerut University. So he's very, very learned, and I am happy that somebody from our fraternity has also learned the law, so he can understand both sides of the picture. So with these few words, I'll definitely invite Dr. Tushar Roy. And before I do that, I'll also request all of you to kindly notice all that webinar we are going to do. Please block those dates, and as Dr. Grewal said, please do give suggestion, especially about the timings. So over to Dr. Tushar Rai.
Thank you, Dr. Chanchal Pal, Dr. Bobby Grewal, Dr. Deepika, and Dr. Amit. And good morning, friends.
We also have Dr. Tushar, we also have our treasurer, the young Dr. Kirti from he's also with us.
Yes, welcome, sir. Welcome and good morning. So what is telemedicine? So before I go into the World Health Organization definition of telemedicine, can I have the first slide, please? So I'll just tell it in short, what is telemedicine? Basically, telemedicine or teleconsultation is, next slide, please, is where you are actually consulting, not in the physical form, or where you're not consulting in your clinic or in the hospital. So that's basically what is telemedicine. And to put it in a very short form, try and avoid it. So that's the short form of the thing. Try and avoid it, because it's okay for short, trivial consultations, but probably not okay for very complex, consultations. And for that, I would put up this quote from a very important case. This was a Supreme Court decision in 2009 by Justice Markandeya Karju and Justice Loda, called the Martin D'Souza case, which all of you must have with you in the clinic. And if you want a copy, just email me and I'll send it to you. It's a very, very important document that you must keep in your clinic. And here is a simple quote. There are many quotes, but this quote is relevant to our talk today. And it says that no prescription should ordinarily be given without actual examination. And that is exactly what you're not doing when you're doing a teleconsultation. You're not actually examining the patient. And the tendency to give prescription over the telephone, except in an acute emergency, should be avoided. This is a statement of two judges of the Supreme Court, and you know about the Supreme Court that they always sit in pairs. So not like the High Court, in the Supreme Court, they always sit in pairs. And if it's a question that requires a bigger bench, three of them sit in judgment. And 3 judge decisions in medical legal cases has only been 7 in the past 70 years. None of them by a 5-bench judge. So this 2-bench decision is very important. So no prescription should ordinarily be given without actual examination. Next slide, please. And this actually can land certain people into trouble, as happened in the Pavaskar case in 2018. So these were doctors who were treating a postpartum hemorrhage over the telephone, and something really bad happened and the patient died. And a case of culpable homicide not amounting to murder was brought against them, and they were arrested. And they were not given bail by the judge, a High Court judge in Bombay, saying that poor outcome after telephonic consultation without examining the patient was gross negligence. And these poor doctors then had to run to the Supreme Court, where bail was then granted to them. So here was a case where inadvertently the doctors may perhaps made a mistake or didn't make a mistake, but something bad happened and they had to run from pillar to post to actually get bail. Next slide, please. So guidelines for telemedicine was actually given to us in March 2020, so almost 2.5 years ago. And they said at that time that an online program will be developed, which has not yet been developed till date. And as and when it will be developed, all RMPs, registered medical practitioners, should complete that course within 3 years of notification. Until then, all ethical guidelines 20202 should be followed. So what is the telemedicine? Next slide, please. So the World Health Organization describes telemedicine. I'll just quote a few lines where distance is a critical factor. So where distance is a critical factor and using information or communication technology and used for the diagnosis, treatment, and prevention of disease and injuries or for research and evaluations. So this is what telemedicine is as per the World Health Organization. Next slide, please. Who is a registered medical practitioner? We know that anybody who has the requisite qualification and is registered either in the state medical register or in the Indian medical register is a registered medical practitioner. And therefore, these guidelines are for registered medical practitioners to carry telemedicine. So essential part is that telemedicine is allowed, but the onus falls on the doctor. So the doctor has to decide whether it is appropriate and sufficient. And if they make a mistake, then the doctor will be held accountable simply because of the fact that the courts say that why did you rely on the patient? Why did you not ask for examination? Why did you not ask for investigation and so on? You are the doctor, you should have known better. So the onus falls always on the doctor. So I go back to my first statement that try and avoid complex teleconsultation. A trivial consultation is absolutely all right. So there are certain exclusions, again, given in the guideline, and that is these consultations are for India only. That is within the jurisdiction of India. That means you cannot do telemedicine with the patient who is in the United States or in UK, even if the patient is an Indian, even if the patient was under your care here in India. As long as it goes outside the jurisdiction of India, telemedicine is not allowed. However, it is the jurisdiction of India could be abroad a ship, for example, in the ocean, which is under an Indian flag. That is also considered to be Indian territory. So not for remote surgery, not for research or education purposes, nothing, no specifications on the hardware, software, or the infrastructure that is used. And of course, not know yet as to how data has to be managed, because one of the most important things in data management is protection of the data so that your data is not hacked into and your patient database is not kind of exposed to unruly elements. Next slide, please. So the kind of telecommunication is divided accordingly. They are divided into 4, but essentially it is the mode of communication, which means how communication is made, whether by video or by audio or by text, the type of consultation, emergency, non-emergency, and who is interacting with the registered medical practitioner, whether it's the patient himself or the caregiver of the patient with or without the presence of the patient, or is it a health worker who is asking the RMP for some information, or one RMP asking the help of another. For example, if I ask the help of Dr. Chanchal in an ENT consultation, so one RMP is asking another RMP. So those are the various kinds of classification. Next slide, please. So video is actually the preferred mode. The reason is that you can get a lot of visual clues, which you may not get either from definitely not from an audio, and maybe not even from a text consultation. So video is the preferred mode. Whenever you do a consultation, video is the preferred mode of consultation. And email, not WhatsApp, is actually the preferred mode of sending reports. And I will talk about how one should maintain telecommunication records and reports as has been stated in the guidelines. But why I say email and not WhatsApp? Because all the emails can be stored, and if you are using Gmail, which I use, it can be searched in a very short time. Within a second, you can search any report that any patient has sent you anytime in the past. Whereas it is very difficult to do so in a WhatsApp message, for example. It will be very difficult for you to search for a report that was sent by a patient a long time ago. And why that is important is because the Indian Evidence Act says that if you claim something, you have to prove it, not the other person. If, for example, you say, I have given him a prescription, the patient can say, no, you didn't. How can I produce it? So you are the one who's supposed to produce the prescription. If he says the patient, this was so-and-so in the report, you're supposed to present the report. The patient says there was no such. Anyway, there could be audio only, which is the least recommended form of telecommunication, or it could be text-based, which could be real-time or asynchronous. For example, you can have a WhatsApp chat ongoing back and forth, or you can have an email, which he sends an email and you reply sometime later. So these are modes of communication. Next slide, please. There are problems, as I said, with the audio. For example, patient identification is difficult. Depends on what the patient says. He says certain things which he feels is important. Doesn't say certain things which may actually be important. So there are very, selection bias, selection of data is presented to you. You are missing non-verbal cues. There is no physical examination or vital statistics involved. Reports cannot be seen. Large amount of data, that is large amount of information that is conveyed to you by a telephone conversation may be difficult to handle from the side of the doctor. And the patient may misunderstand your prescription or misunderstand your instructions. Then who is at fault comes into the question. And usually, at least in our cases, there is usually no payment. So next slide, please. Text message is, of course, easy because it's easy to record images and data and reports. And I'll tell you why it is important to do so, because you are legally bound to keep the records, as I will show. And it's also an asynchronous mode of communication. You are not bogged down as in an audio. Both of you have to be connected at the same time. Whereas in a text message, he can send you and you can reply at your own convenience. However, in a text message, you cannot be sure of the identity, who is the patient, and so on. And of course, miss visual clues. Next slide, please. So type of consultation, and this is very important, and I'll spend a little time on this. It could be an emergency consultation, or it could be a non-emergency consultation. Now here is very important. Emergency consultation, you are not supposed to treat the patient. In an emergency consultation, please do not treat the patient. Only give first aid and only facilitate referral. That is, which hospital should we go, arrange for the ambulance, and so on, and give first aid. The only place where you can treat is in a remote patient where no immediate medical facility is available. But in a place like Delhi, where medical facility is 5 minutes, 10 minutes away, treating the patient over the telephone or over any form of video consultation is not called for, and one might get into serious trouble. So in an emergency consult, and this is given in the telemedicine guideline, give only first aid and facilitate referral only. Non-emergency consultation can be of two types. They've called it the first consult and the follow-up consult. The first consult, of course, is whether they were even for diagnosis purposes and so on. And follow-up consult is with the same RMP for the same illness. Next slide, please. Then I'll talk about this in a little bit detail subsequently because it's very important. And these are the elements. And the most important thing I've colored here is the context. That is, the RMP must decide whether the format that is being used, text, audio, or video, whether it is appropriate and sufficient. For example, if depending on the complexity of the case, depending on the need of examination or investigations, one can decide while having the consultation, no, this is a complex case, I need to examine the patient, I need more investigation. So one can pause the consultation, ask them to go to the nearest hospital for a physical examination, or ask them to get further investigation done and then come back to you. So the appropriateness and whether this forum is sufficient is entirely in the domain of the doctor, and the doctor must decide whether to continue with the telemedicine consultation or pause the telemedicine consultation and give further instructions as how to proceed. And of course, identification of the doctor and identification of the patient is important. And of course, consent is also required. And I'll talk about consent, where consent is required subsequently. Next slide, please. So whenever one takes this, identification of the patient is important. And identification of patient is not only by the name, age, and the sex, but something additional. That additional something could be a telephone number, email ID, or even the address of the patient, because there could be several Suresh Kumars, for example, or whatever, or Bimla Devi, for example. You could have several Bimla Devi. So how do you confirm? Simply not by the age and the name, but also something additional. And this is given in the format which I will show you, in the format that has been recommended in the telemedicine guidelines, and additional information, whether it is an address or telephone number or email, is necessary. If it's a minor, consultation can only be done when accompanied by an adult, and that adult must be identified who the adult is and what is the relationship with the minor. And if the consultation is with another registered medical practitioner, then his name and his qualifications and your name and your qualifications must be noted down. Next slide, please. So what about consent? Of course, consent is implied. So everything that we do is based on the consent of the patient. We are not doing anything without the consent of the patient. So consent is implied if the telecommunication or telemedicine has been initiated by the patient. If the patient asks for a teleconsultation, of course, that consent is required. No explicit consent needs to be taken. But if we find that the caregiver is asking for the telecommunication, without the presence of the patient. So patient is not present, only the caregiver, his daughter, his son, his wife is asking for the teleconsultation, then explicit consent must be taken. And so also for the health worker, or when the RMP, another RMP asks for consultation, then explicit consent of the patient must be taken. And this explicit consent of the patient has to be recorded. So it has to be taken and it has to be recorded. And I think the best way to record that is if they send you an SMS or a WhatsApp or an email saying that they consent to so-and-so doing a consultation on their behalf. This is a legal requirement. Next slide, please. So first consult. So the first consult is the first consultation. You're consulting the patient for the first time. And if more than 6 months have passed, so you've consulted the patient, and then now 6 months later, and the 7th month the patient is coming to you, then again it becomes a first consult. And I'll tell you the importance of that because what medicines you can prescribe and how you can go about it depends on whether it's a first consult or a follow-up consult. Also, if it is less than 6 months, but the patient is now consulting you not for the same disease or the same health condition, but for a different disease, then again it becomes a first consult. Next slide, please. So follow-up consult is when you are consulting the same RMP, the same doctor is being consulted for the same or different disease, or for the same disease after 6 months. So you've seen the patient. After 6 months, the patient comes to you. That becomes a follow-up consult. But if after 6 months the patient comes to you for the new symptom, then that is a first consult. So it's not a follow-up consult if there is a new symptom or new disease, if the RMP does not recall the context of the previous treatment and advice, then that becomes a first consult. Why is it important? It's important because the telemedicine guidelines has divided medicines into 4 groups. Next slide, please. The 4 groups are, they call them group O, A, B, and prohibited list. Prohibited list is a group of medicine that can never be prescribed over telemedicine. For example, narcotics, certain cancer drugs cannot be prescribed over that, and there is a prohibited list given by them. And if anybody gives the prohibited list on a telemedicine consultation, then this is per se negligence and constitutes misconduct as far as the ethics guidelines is concerned. So list O, A, and B. O is generally very simple medicines or over-the-counter medicines, cough syrups, lozenges, paracetamol, things like that. So that can be done, and I will tell you when that can be done. A is a medicine that can be used in the first consultation. A is a group of medicines that can be used in the first consultation, and in the first consultation, that is a video consultation. So not either by an audio consultation or a text consultation, but only when the first consultation is a video consultation can this group of medicines be used, and B group of medicines is for follow-up consultation. So O is very simple medicines which can be used in any consultation. A is a group of medicines that can be used in the first consultation, and B is a group of medicines that can be used in follow-up consultations, and prohibited list is a group of medicines that can never be prescribed over telemedicine. Next slide, please. So what is list O? List O is medicines which are safe, used for common conditions or over-the-counter treatment, like, for example, paracetamol, ORS solutions, some painkillers, cough lozenges, and so on. And medicines that are deemed necessary during public health emergencies. For example, we had this COVID, and in COVID, you could prescribe certain medicines which were allowed at that time in an emergency. The government can allow you to prescribe certain medicines even if it is a first consultation. Next slide, please. So list A, as I said, medicines that can be used in the first consultation, and if the first consultation is a video consultation. So if it's a text consultation or an audio consultation, you cannot use this medicine, and you have to make sure that this consultation was appropriate and sufficient for the condition. It was not complex conditions, so that a physical examination or certain investigations were not required. It can also be used, list A can be used for re-prescription, and these are usually a group of medicines that are safe with low potential for abuse. Next slide, please. List B is a medicine for follow-up consultation, and these are basically add-on medicines. So you've already been treating the patients for, say, diabetes, so you add perhaps sitagliptin to his metformin, or you add a BP medicine to his. So this is the kind of thing that you can have on a follow-up consultation. List B can be used in follow-up consultation. Next slide, please. So prohibited list is a group of medicines which have high potential for abuse. Schedule X medicines under the Drugs and Cosmetic Rules or the Narcotic Act. So these are medicines that cannot be used in telemedicine at all. Next slide, please. So here is actually the list that has been picked up from the telemedicine guidelines, and this is exactly what I've just told you. So the first group is list O. It's over-counter, very simple medicines, multivitamins, stuff like that. List A is the usual medicines for which a video consultation is sufficient. For example, a skin condition, for example, things like that. And list B is for follow-up consultation. Next slide, please. So here's a very important thing. I'll spend just a minute. So list O can be used in any form of consultation, and whether it's a first consultation or a follow-up consultation. List O can be used. List A can be used for first consultation and for follow-up consultation, but only if it's a video consultation. It cannot be used in any other form. So list A can only be, and of course, follow-up list B is a follow-up thing which you can, that is addition of medicines to a diabetic patient, so that can be done in any form of consultation, whether it's video, text, or audio. Next slide, please. So after the consultation, one must prepare the prescription, stamp and sign it and transmit it. One can now even use an e-prescription, and that e-prescription is also valid. What exactly that constitutes, I'm not sure. What exactly they mean by e-prescription. What I do is generally I make a prescription, I sign it, I stamp it, and then I transmit it by email to them. You can also transmit the receipt and the invoice to them. Fees, you can charge your normal fees. There is no limitation to the amount of fees that you can charge, as long as it is considered reasonable. And it is preferable not to use bank details, because certain kinds of frauds have been committed when you give them your bank detail number and ask them to do NEFT, IMPS, RTGS. Better to use non-banking modes of payment like Paytm or UPI. Now UPI can be done from any bank account. Next slide, please. So this is the format that has been given for the prescription, for the actual prescription. The format, if you look at it closely, is it says, of course, the usual thing: your name, your details, and the patient's name, date of consultation, age, and gender. Of course, height and weight if the patient is minor, and of course, LMP if the patient is pregnant. And in the box on the left, it says address. What it basically means, and if you look at the ethical guidelines of the Medical Council of India, it is not only address, but it could be the email or the phone number. So something in addition to the name and the age by which the patient can be identified. And then of course the usual prescription. And what you cannot see is in that prescription format, it is written, two words are mentioned there. Number one, medicines in capital letters. So that's what is mentioned there, medicines in capital letters, so that any illegible handwriting or difficult to understand handwriting cannot be misunderstood by the chemist or misunderstood by the patient. So it is not preferable, it is mandatory that if you are not using a printout, if you're using a printout, that's fair. You don't have to make it bold in a printout. But if you're using handwriting, then the name of the medicine has to be written in capital letters, and the generic name must be mentioned perhaps in brackets. So basically two things are written in this which are mandatory and legally required. Not doing so would constitute a misconduct, and that is writing the name of the prescription in capital letters and also writing the generic name somewhere perhaps later in the brackets. Next slide, please. So here are some legal issues. And the first legal issue is regarding emergency. So until and unless the patient is very remote, has no access or no immediate access to medical facilities, then please do not treat emergency over. Next slide, please. Please do not treat any emergency over telemedicine. Just give first aid advice. Say, for example, you can give some painkillers or gas medicine, and then ask them to go to a nearest hospital and facilitate their referral. You can call up the doctor there. You can arrange for the ambulance and stuff like that. So first consultation, as I said, the first consultation usually should be a video consultation, because without a video consultation, you cannot write any medicine other than list O medicine. So without that, you cannot. So it has to be a video consultation, the first consultation, and you must make sure the onus is on the doctor to make sure whether it is appropriate and sufficient. If you find it is becoming very complex, or you need further investigations, or you need to examine the patient, you can pause the consultation at that time, ask to get it done, and that's it. So it's the onus of the doctor to stop the consultation at any time, pause the consultation at any time. The doctor need not complete and need not give a prescription at the end of the consultation. So medicines that can or cannot be prescribed are just listed, and explicit consent has to be taken if they are not doing it directly with the patient. But if you're doing it with a caregiver in the absence of the patient, or with another health worker or with another doctor, then explicit consent has to be taken and has to be recorded. And of course, it has to be within the jurisdiction of India. Next slide, please. And these are some things I've picked up, and I'll go very rapidly. And this is all from the telemedicine guidelines. You must confirm the ID. You must have the consent as it is required, and do not proceed if examination is critical. Next slide, please. So issue the prescription and transmit the prescription. Format of the prescription I've just shown you, which they have given in Annexure 2. You can sign a scanned or even give an e-prescription, and you have to write the appropriate or provisional diagnosis. So provisional diagnosis must be mentioned in the prescription. If it is not, then it is considered to be a professional misconduct. Next slide, please. This is a very important thing, and something which many of us may find difficult to do, and that is, it is stated that keeping a log of all telemedicine consultations is mandated. It is not voluntary. It is not by choice. It is mandatory, and you must maintain a record of all prescriptions, all lab reports, all images that have been sent by the patient, and you have to produce them. And therefore, I go back to what I said, that perhaps email is the best way of asking them to send you, because email can be searched, email can be archived, email can be searched. But a WhatsApp message, for example, you may not be able to get a lab report that the patient has sent you perhaps 3 months ago. So here's the detail. Next slide, please. So here's the detail from the telemedicine guidelines 3.7.2. Maintain digital trail documentation of consultation. It is incumbent on the RMP to maintain the following records, documents for the period as prescribed from time to time. And the period is, of course, we call the period of limitation. That is in law the time by which the patient must file a complaint. For example, something has happened today, he cannot file a complaint after 6 years. He has to file it within 3-year period of time. If he does not file it within the 3-year period of time, then he is barred by a principle called limitation. So he is limited from filing it. So till at least 3-year period of time, one must keep all these documents. And what are the documents that one must keep? A log of the record of the telemedicine, that is phone log, chat log, etc., etc. Next slide, please. So the patient records, his reports, his documents, his diagnostics, his data. This is all written in the telemedicine guideline. I'm just quoting it from there, 3.7.2.2, whatever. So this is what has to be maintained by the RMP that has been utilized in the telemedicine consultation should be retained by the RMP. Specifically, in case a prescription is shared to the patient, the RMP is required to maintain the prescription record as required in inpatient consultation. So all these records must be kept by the doctor themselves. Next slide, please. So certain cautions before I end this talk. Phone calls, video calls, emails, and text messages can all be recorded and usually are. So emails can be archived, text messages can be, video calls can be recorded, phone calls can be recorded. So please be careful as to what you are saying. And for God's sake, do not make any comment on any treatment that has been given for another RMP, because that usually opens a Pandora box, not only against that RMP, but against you also. Thank you very much. Next slide, please. Thank you very much.
Dr. Tushar, that was an eye-opener of a presentation. And it is important because this topic is not addressed. People were pushed into teleconsultation. They were pushed into teleconsultation, and they adopted it very fast because it became a very simple and easy way of continuing your practice. I mean, during COVID, it was just bada maza aa gaya. There were, doctors who were going on. But of late, what has happened is that we have started getting numerous complaints by patients based on teleconsultation. So therefore, this topic is very important.
You carried the topic so well. The list of the medicines which we can keep as a record, you can send me a WhatsApp, I can circulate. And the prescription. These are two important documents we should have. So you have overemphasized every point so that it goes to our mind about the consent, everything. I like you to at least have those two documents shared.
We don't want this to be just one occasion. The continuity will come with Dr. Tushar Rai giving us the sample prescription, certain medication, which we will publish in our medical forum. Dr. Podar would like to say something. Dr. Lamba would also like to say something. Dr. Poonam Gulati and Dr. Bakshi. So, Pehle Dr. Podar, please welcome and you could give your comments.
Yeah, thank you. I think I must thank our branch president, Dr. Chanchal and Dr. Grewal to organize this type of webinar, because we have had many on scientific subjects. And I also thank Dr. Tushar Roy for a wonderful lecture on telemedicine. So my question is, it's a boon. Telemedicine is a boon, we know, for us. But you have said so many precautions which we were not taking, like keeping all the records. You said you have to keep records for 3 years. I think this is a lesson. I think most of us were not keeping this record for 3 years. Maybe we have started consultation 2 years back. So we must be very careful in future now.
Very nice, Dr. Podar. Thank you for the kind words. And we will be publishing the article by Dr. Tushar Rai in our medical forum. And this dialogue must continue. So the next person who wanted to say something, Dr. Bakshi, would you like to say something?
Yeah, thanks, Dr. Tushar. You've guided us well. The only thing is on the prescription, as we have been doing earlier also, and we are amongst discussions with people, do we write that the consent has been taken? Do we write that inform SOS for an emergency? We put it on the patient that you inform us back. Some onus has to be on the patient also. Supposing it doesn't revert back when there is an emergency or when there is a reaction to a medicine and it doesn't, I would not know whether I've written a medicine and that he has reacted to. So he has to come back. So on every prescription, we should be writing inform us in emergency or the guidelines or red flags. Additional red flags, 1 or 2 must also be written on the prescriptions so that we put it on that patient. That's my suggestion. Thank you.
Yes, Dr. Tushar, please.
Yes. What was the question? One is the red flag. Yes. Basically, one should, there is not only the onus falls on the doctors only, the onus falls on the patients only. If there is any problem arising from the prescription, because, we are writing everything in good faith, but if there is a reaction to a medicine or something is not tolerated, then the patient should come back to us. Writing that on the prescription is a good idea, although it's not mandatory, but I think it's a good idea. What was the second, what was the first question?
Whether consent has been taken.
Consent, yeah, okay. No, consent, you do not have to write on the prescription that consent has been taken, because if the patient comes to you, then the mere act of him coming to you or asking for the teleconsultation is implied consent. So then consent need not be written. But if the patient is not there, if the patient is not involved, for example, you are talking to the daughter, for example, or you are talking to his treating family physician or his treating doctor, for example, then consent has to be taken. And then, of course, it has to be noted that consent of the patient has been obtained for this consultation.
Thank you. Thank you so much.
Dr. Lamba also wanted to say something.
Yes, he says, first of all, congratulations. And it's a very, very knowledgeable, I think, started by Dr. Tushar Rai. Sir, in your initial slide, you have mentioned about the mode of payment. And when we have fulfilled all the criteria for telemedicine, you have in your slide mentioned no RTGS, only Paytm has to be taken. I think what is the criteria? No RTGS and
no. This has got nothing to do with telemedicine. This is generally to do with finances, because you see, if I go and put money in your account, I put 2 lakhs in your account and then tell the ED that he has got money from somewhere, problems occur. You see, but with the Paytm and especially with the UPI system, that means from any bank account, you can pay by UPI without knowing your bank account number. So that is generally financially now considered to be a better way of payment. Nothing to do with telemedicine, simply to do with payment. So you don't want your bank account details to be known to all and sundry. You can give them your Paytm account, which is your mobile number at Paytm, most likely, or your UPI account. For example, I have Dr. Tushar at PNB. So you can just, from any account, you can, UPI me the money. So you need not know my bank account number. It's just a prudent financial way of doing things. You can talk to your financial advisor whether that's the correct way. But what I've been told, that don't give your bank account number to all and everyone.
True.
Dr. Tushar, Dr. Vinod Rana would like to ask a question, and Dr. Kartik Kohli has a question. I'll just read it. I put it in your chat box, Dr. Tushar.
Okay.
Yes, Dr. Raina or Dr. Pununguladi wanted to say something.
Good morning, everybody.
Yes.
Thanks, sir. It was so nice. And thank you, Dr. Tushar. My question is, sir, I am a HIV specialist, and sometimes there are calls from different parts of country that they want a drug which is called post-exposure prophylaxis, PEP. And they ask us for the teleconsultation. And as the HIV drugs are category H drugs, and we need consent from the patient. My question is, sir, if a patient from Assam, Dibrugarh, he calls me, Dr. Saab, I need a prescription, and he is it legally possible to give him prescription, or I have to send him to any medical practitioner, and I can talk to that medical practitioner that what medicine is to be used, and that prescription can be given to that patient in that emergency time?
Okay, so actually I'm not sure, because you have to go through the list that has been prescribed by the telemedicine guidelines. So whether it falls into which category. If it falls into category A, that is where you can use it as a first consult, is a video consult, then you can prescribe. But if it does not fall into category A, then of course the second option that you said, ask him to go to a doctor, and then you talk to the doctor. That means you are doing a video consultation, or you are doing teleconsultation with the doctor, not with the patient. Yeah, with the doctor, and then the doctor can prescribe using your thing. I think the second option would be a safer option. The first option may or may not be. It depends upon whether that drug is allowed in the first consultation list or not. That I'm not sure, because it's a long list. I'm not sure whether that particular
Dr. Tushar, with this question Dr. Lamba has asked, these days, many a times, even I do that, I tell the patient to go to a chemist.
Yes.
And I speak to the chemist and tell him the medicine. Would that be considered a safer way?
Much safer way. Much safer way. Much safer way. Because you can talk in, number one, you can talk technical details with the chemist. And number two, you don't have to spell out A for apple, B for ball with the patient. You see.
Dr. Tushar, Dr. Karthik's question, you may have read it, please.
No. What is the question? I'm not finding it.
Okay, I'll just read it out. I'll read it out.
Yes, sir.
It says, if a consultation is being done through hospital software,
yes,
and a doctor leaves that hospital in subsequent time frame, the responsibility to reproduce the prescription is of hospital or of the doctor, as hospitals don't always give access to medical records beyond that consult. This is Dr. Kartik Kohli, who is a consultant at Sitaram Bhartiya.
Yes. It is a responsibility of the hospital. See, basically, your job, say, we are talking about medical records now. So medical records, the doing of the medical records or writing of the medical records is the job of the doctor. Maintaining the medical records is the job of the hospital. It's very clear. You don't have to maintain the thing, and they have to produce it. It is not a question of option. They have to produce it within 72 hours of asking for it, 72 working hours of asking for it. So if you are using a hospital software, the records are with the hospital. It's the hospital's job to maintain that record.
Okay, that's Dr. Kartik, would you like to ask any further clarification? Deepika, can you please bring him on the panel if he wants? Kartik? There's one more question. Dr. Vikram Vinayak said, for consent of patient, many times the caretaker has to go home. So that means the caretaker has come to your clinic. Dr. Gudev Singh, you wanted to ask some question, please?
No. For that, he can just pick up the phone. As I said, consent can be in any form. It could be audio, text, video, whatever. Now you can, from your clinic, you can do a WhatsApp chat with the patient, or you can phone the patient and you can ask, and I'm with the doctor. Are you okay if I talk about your condition with the doctor? The doctor says, just listens to him and says yes, and that's all right. Notes that explicit consent has been taken in such and such format.
Dr. Gudev Singh is asking,
sir. Yeah. Good morning, sir.
Yeah, good morning.
Actually, I was asking, we frequently hold like CME programs on Zoom and other mediums. So are these rules applicable there also, and what are the legal implications, if any?
If you're talking amongst yourselves, amongst the doctor group, then this is not applicable. You're just discussing this thing. But if patients are involved in that, then that might consult as a consultation, because you are then giving not prescription, but you are giving diet advice, exercise advice, and other health tips, which are part of prescription actually. So it might. Patients are involved in.
You mean if you are discussing any patient among the doctors, and patient is not there, no problem. Okay.
As long as you don't take the identity of the patient.
Yeah.
Patient's identity is not exposed. You don't take the name. You say male, age, so and so. Then that's not a problem. Anonymized data can be discussed anyway. No problem.
Yes, Kartik.
Okay, thank you.
Kartik, you can ask your question further.
Sir, a lot of times now, first of all, I mean, I must congratulate IMA South Delhi Branch, all the stakeholders, as well as Dr. Tushar Roy for this excellent deliberation on a Sunday morning. I think it was quite informative and very educative for us. And as teleconsultation is getting formalized, so this is sometimes the preferred mode as a first consultation by a lot of patients, even by doctors. My only concern here is, sir, a lot of patients at times from different hospitals, considering that you are in a tertiary care center, take a consultation as a second opinion, whether they should transfer the patient here or not transfer the patient here, or whether the treatment which is being given by a fellow colleague, suppose in Lucknow, is all right or not. I mean, a lot of time that consultation is more of a discussion. And then in that case, you might say that, okay, you continue these medications, and then if the situation gets better with respect to ventilation, you can then shift the patient here or not. So, I mean, what kind of we are in a very fuzzy state there. I mean, none of the guidelines, I mean, laid by you or for that matter by NMC are not, I mean, followed there. It's more of a discussion. We don't necessarily in every consultation of that sort give a prescription as well. And a lot of times we said that continue the same treatment, and when the situation becomes better, you may transfer the patient. So, I mean, is that okay, or like, are there any norms for that?
Very good, very good.
I think you're absolutely right. It is a fuzzy situation.
Absolutely.
Nothing has been noted down as this thing. It could still constitute telemedicine consultation, because consultation does not have to result in a prescription. As I said, you discuss something, you advise something. This advice is also a teleconsultation. That is also a consultation, and you can charge your normal fees for that. There's no problem whatsoever. As I said, the situation is very fuzzy, because you are commenting on the treatment of another RMC, which I am very skeptical, and I don't advise anybody to comment. As long as you say it's okay, that's okay. But to go other way, because then the patient loses faith in the doctor who's treating there, and so on and so forth. So that's a very fuzzy, difficult. I understand it's a very difficult situation.
Maybe a good discussion on viewing another prescription can be a topic for a presentation by Dr. Tushar Roy. Yes, Dr. Vikram Vinayak, you wanted to ask something.
Yes.
Can you prescribe Sorbitrate on the telephone? Can you prescribe Ecosprin AV? And he says on telephone, patients don't pay, as they say, Doctor Saab, aapse baat ho gayi.
That's what I said. That's exactly what I said when I was listening to the audio. At the last, it was saying usually there's no payment, because in the West, if you call somebody professionally, you have to pay for his time. He bills you as per the time that you have spent on the telephone. But here, an audio call for us apparently is free of charge. Yeah, that is unfortunate, I think, because you are giving a professional time.
Can you prescribe Sorbitrate?
Yes, you can prescribe Sorbitrate, you can prescribe Ecosprin AV, as long as you also tell them that now after taking this, go to the hospital.
Don't. Right.
No, go to the hospital.
That's right. Dr. Arora,
so you take your Sorbitrate and go to the hospital. Yeah.
Dr. Arora, you may ask your question.
Sir, I have suggestion. I insist most of the patient to take the vitals with the help of anybody nearby and write on the paper and transfer me. Only then I prescribe the
Very good idea. Very good idea. Excellent idea.
Because a pulse oximeter, most of the
very good idea. Very good idea.
Instruments
see
have.
What Dr. Arora is saying, even if it is not accurate, Dr. Roy, if I've told a patient, please take your these blood pressure, oxygen, etc. On paper, I record it. It is a safety measure taken by me, and I think in law that would hold as a good practice. What do you say, Doctor?
Absolutely.
Good advice.
Even any investigations which they have done previously, they can be transmitted to you, and you can have a look at them before you initiate the consult.
Especially during COVID, we were asking them to show their pulse oximeter also.
That's right.
By the patient, then onus lies on the patient. And as for the consent on the telemedicine, you were saying, when the patient calls up, always ask patient to call you, so that when he's calling or say, please give me time. I always tell them, please write your name, age, phone number, and tell that ask me for a time slot. I'll send you the time slot. So that itself is a consent. Even the taking, then I ask them that ask the patient to call on another call. Both of you should be there. So then person is calling, then definitely it is an implicit consent.
I think as a follow-up of this presentation, the way people have responded with the type of knowledge Dr. Roy has given as a follow-up, it would be a good idea if people can share some of the difficulties and problems they face during teleconsultation, and we will take it up for discussion as role models for others to learn. So first of all, before I invite our treasurer, Dr. Kartik, to give a formal vote of thanks, let me take my opportunity to thank Dr. Deepika Chhabra and Dr. Saxena from Jagsonpal. It's a big support to have Jagsonpal do the entire technicality, because I'll tell you, it's not easy doing technical issues with holding such webinars. So one big thing is off your mind. And Deepika and Amit Saxena, thank you very much.
Thank
you. We will continue this tomorrow or next Sunday. And now I invite Dr. Kartikeya to give a formal vote of thanks on behalf of the branch to all stakeholders. Thank you, Amit. Welcome, Dr. Kartik.
I'd like to thank Dr. Tushar Roy, sir, for this very informative and this interesting session, sir. And also, sir, Jagsonpal Pharma for their whole technical support and for being our academic partners. The whole team of IMA South Delhi Branch and all the people who have attended, all the attendees, thank you very much. And we shall meet soon next week again on this very interesting topic. Thank you also.
Welcome, and thank you once again, Dr. Tushar Rai, a personal, you've given the oxygen to this effort of ours. Thank you very much.
Thank you so much.
Have a good Sunday.